This recording will go over hydronephrosis and hydroureter, renal vascular disease, and diabetic nephropathy. Hydronephrosis and hydroureter are problems of urinary elimination with outflow obstruction. Urethral strictures obstruct urine outflow and may contribute to bladder distension, hydroureter, and hydronephrosis. Prompt recognition and treatment are crucial to preventing permanent kidney damage. In hydronephrosis, the kidney enlarges as urine collects in the renal pelvis and kidney tissue. Kidney pressure increases as the volume of urine increases. Over time, sometimes in only a matter of hours, the blood vessels and kidney tubules can be damaged extensively. In patients with hydroureter, enlargement of the ureter, the effects are similar, but the obstruction is in the ureter rather than in the kidney. Ureter dilation occurs above the obstruction and enlarges as urine collects. And you can see in these pictures here in your PowerPoint presentation where a stone is causing an obstruction, resulting in hydronephrosis. Lay person term would be water on the kidney. And then here's the stone is obstructing a little bit lower, so it's actually affecting the ureter also, resulting in hydroureter. Urinary obstruction causes damage when pressure builds up directly on kidney tissue. Tubular filtrate pressure also increases in the nephron as drainage through the collecting system is impaired and glomerular filtration decreases or ceases. Kidney necrosis can occur. Nitrogen waste products such as urea, creatinine, and uric acid, and electrolytes such as sodium, potassium chloride, and phosphorus are retained, and acid-base balance is impaired. Causes of hydronephrosis and hydroureter include tumors, stones, trauma, structural defects, and fibrosis. In regards to assessment, obtain a history from the patient focusing on known kidney or urologic disorders. A history of childhood urinary tract problems may indicate previously undiagnosed structural defects. Ask about his or her usual pattern of urinary elimination, especially amount, frequency, color, clarity, and odor. Ask about flank or abdominal pain, chills, fevers. Malaise may be present with UTIs. Inspect each flank to identify asymmetry, which may occur with kidney mass, and gently palpate the abdomen to locate areas of tenderness. Palpate and percuss the bladder to detect distension or use a bedside bladder scan. Gentle pressure on the abdomen may cause urine leakage, which reflects a full bladder and possible obstruction. Urinalysis may show bacteria or white blood cells if infection is present. Blood creatinine and BUN levels increase and GFR decreases. Serum electrolyte levels may be altered with elevated blood levels of potassium, phosphorus, and calcium, along with metabolic acidosis due to bicarbonate deficit. Urinary outflow obstructions can be seen with ultrasound or CT. Urinary retention and potential for infection are the primary problems. Failure to treat the cause of obstruction leads to infection and acute kidney injury. If obstruction is caused by a kidney stone, it can be located and removed. After stone removal, a plastic stent is usually left in the ureter for a few weeks to improve urine outflow in the area irritated by the stone. The stent is later removed by another cystoscopic procedure. When an abnormal narrowing of the urinary tract or a stricture causes hydronephrosis and cannot be corrected with urologic procedures, a nephrostomy is performed. Most nephrostomy drains provide only external drainage or diversion. Other styles of nephrostomy drains enter the kidney and extend to the bladder, draining urine out to a bag or past a ureteral obstruction and into the bladder. Patient prep for the patient receiving a nephrostomy includes being NPO for 4 to 6 hours before the procedure. Clotting studies, including INR, PT, and PTT, should be normal or corrected. Drugs are used to reduce hypertension. With the nephroscopy tube, the catheter tip remains in the renal pelvis, and the external end is connected to a drainage bag. The procedure immediately relieves the pressure and prevents further damage to the kidney. The nephrostomy tube remains in place until the obstruction is resolved. In terms of follow-up care, assess the amount of drainage in the collection bag. The amount of drainage depends on whether the ureteral catheter is also being used, which is a separate drainage bag. If urine is expected to drain into the collection bag, assess the amount of drainage hourly for the first 24 hours. If the amount of drainage decreases and the patient has back pain, the tube may be clogged or dislodged. Monitor the nephrostomy site for leakage of urine or blood. Urine drainage may be bloody for the first 12 to 24 hours after the procedure and should gradually clear. If prescribed, the nephrostomy tube can be irrigated with 5 mL of sterile saline to check patency and dislodge any clots. It is common for diuresis to occur when a nephrostomy is placed for obstruction. Monitor Is and O hourly for the first several hours and inform the surgeon if the patient begins to have symptoms of dehydration. Assess for indications of infection. After nephrostomy, monitor the patient to recognize indications of complications, including decreased or absent drainage, cloudy or foul-smelling drainage, leakage of blood or urine from the nephrostomy site, or back pain. If any indications are present, respond by notifying the surgeon immediately. Next, we're going to move on to renal vascular disease. Anything that affects renal arteries and the amount of blood flowing into the kidneys can cause problems. Uncorrected renal vascular disease, such as renal vein thrombosis or renal artery stenosis, atherosclerosis, or thrombosis, causes ischemia and atrophy of kidney tissue, leading to severe impairment of urinary elimination, fluid and electrolyte balance, and acid-base balance. Patients with renal vascular disease, particularly those over 50 years of age, often have a sudden onset of hypertension. Patients with high blood pressure but no family history of hypertension also may potentially have renal artery stenosis. Renal artery stenosis from atherosclerosis or blood vessel hyperplasia is the main cause of renal vascular disease. Atherosclerotic changes in the renal artery often occur along with sclerosis in the aorta and other major vessels. Fibrotic changes of the blood vessel wall occur throughout the length of the renal artery. Key features of renal vascular disease include significant, difficult to control high blood pressure, poorly controlled diabetes or sustained hyperglycemia, elevated serum creatinine, and decreased GFR. Hypertension usually first occurs after age 40 to 50, and often the patient does not have a family history of hypertension. Diagnosis is made by magnetic resonance angiography or MRA, renal ultrasound, and radionuclide imaging or renal arteriography. Identifying the type of defect, extent of narrowing, and conditions of the surrounding blood vessels is critical for treatment choice, as is the patient's overall health. Many patients with renal vascular disease also have cardiovascular disease, and both conditions require treatment. Renal artery stenosis may be managed by drugs to control high blood pressure and by procedures to restore blood supply to the kidney. Endovascular techniques are non-surgical approaches to repair renal artery stenosis. Stent placement with or without balloon angioplasty is an example of endovascular intervention. After the procedure, the patient usually remains under close observation for 24 hours to monitor for sudden blood pressure fluctuations as the kidneys adjust to increased blood flow. Renal artery bypass surgery is a major procedure and requires 2 or more months of recovery. A bypass may be performed for either one or both renal arteries. Diabetic nephropathy is a vascular complication of diabetes mellitus and the leading cause of end-stage kidney disease. The severity of diabetic kidney disease is related to the degree of hyperglycemia the patient generally experiences. With poor control of hyperglycemia, the complicating problems of atherosclerosis, hypertension, and neuropathy are more severe and more likely to cause kidney damage.